The aim of this video is to give trainees a practical introduction to the implementation of workplace-based assessment in general surgery. Just a quick recap on workplace-based assessment. It is a part of competency-based medical education, which is the modern method of training and assessment of postgraduates. Workplace-based assessment allows the assessment of competence in the workplace. It has significant educational value. And the framework for assessment is provided by EPAs, or entrustable professional activities. In a programmatic assessment system, multiple low-stakes observations by multiple raters are entered into a portfolio, and then this is reviewed by a group, often called a competence committee, to make high-stakes decisions regarding progression or eligibility to write the exit examination. And workplace assessment will start on the 1st of October across all units in general surgery as part of a project. So the entrustable professional activities to assess in workplace-based assessment in general surgery were decided on by a stakeholder team, which included consultants, educationalists, and importantly, registrars. And this was done after reviewing international literature to see what other centers had done. And the four broad domains that were chosen was managing general surgery outpatients, managing general surgery inpatients, managing the acute intake, and lastly, performing core general surgical procedures. The three consultative EPAs, being outpatient, inpatient, and acute intake admission, include a range of activities, and it's important to understand the pathology here is undifferentiated. It can be really anything that the general surgeon encounters. In an outpatient setting, includes SOPD, includes pre-op or pre-clot clinics, and as well as multidisciplinary team meetings. For the inpatients, it could be pre or post-op patients, patients admitted purely for workup, or patients admitted for non-operative management. And the acute intake obviously includes all on-call admissions. I said before that the pathology is undifferentiated, and all patients are included for that activity. So if a trainee sees 5 patients and presents them on an inpatient round, the assessment is based on those 5. And it's important that the assessment or observation is performed. The expectation is that the trainee is at a generalist level, not at a subspecialist. Although they may be rotating through that unit, that's not the expectation of their depth of knowledge. So 7 procedural activities were selected. The first is a hernia repair. Again, this is somewhat undifferentiated. It could be a groin, it could be ventral, it could be open laparoscopic, not very complex hernias. A cholecystectomy, a laparotomy, which can be elective or emergency and include a wide range of tasks like bowel anastomosis, resection, splenectomy, a gastroscopy, which can be diagnostic or interventional, and appendicectomy, which can be laparoscopic or open, except not a midline lap for a really unstable patient. That would fall under EPA number 3, a laparotomy. And then performing a mastectomy or lumpectomy with an axillary procedure, and lastly, a major lower limb amputation. So the first 3 months of the study, that being October to December of 2022, we will start off with quite a small amount of observations that are required. And note that I use the word observation. These are not really assessments. They're not high stakes. It's not pass-fail. Observations of performance or practice means it's very low stakes, and it's mainly formative and educational in objective. So for the junior rotations being C14 ICU or Red Cross Senior, those trainees will be required to perform 1 inpatient observation and 1 acute intake observation. So it's only 2 per 12-week rotation. We have to increase this at a later stage. So this is part of an introductory phase for everyone to get used to the system. So it's very, very light to start off with. The cutting rotations, they will need to do 1 acute intake observation and 1 operative one. In relief, 2 of any. In the firms, for upper GI, HPB, and endocrine, 1 outpatient observation and 1 operative one. In colorectal and vascular, 1 outpatient and 1 inpatient, and transplant, only 1 operative observation. So how does an observation work? It's important to understand the registrar is primarily responsible to initiate an observation. However, the consultant may initiate if they feel that they want to or they need to. And as I said before, an activity is identified as an observation, and it's important to avoid the word assessment so as not to create anxiety, to create the perception that it's a high-stakes pass-fail situation, which it is not. So the activities identified as an observation by the trainee or the consultant before it takes place. This means that the supervisor can pay closer attention to the trainee's performance, especially to the degree of supervision that they need. After the activity, the trainee sends a request. This is done via their smartphone, which they have on them at all times. And it's a very short Google form, and that will be the next video, which I'll show. This request is immediately emailed to the supervisor, and also immediately an SMS is sent to the supervisor. This is an example of the email. So it says a new observation request from a registrar, and it describes the observation, what procedure, the date that it occurred, which rotation they were in, and it gives a link for the consultant that they can click on through the email to open up the observation form. And it also says an SMS was sent to their phone number. So this would be the SMS that is sent, a brief message, a new observation requested from this registrar, and it gives the consultant the link as well that they can tap on their smartphone and immediately will open up the observation form. So the observation form for a procedure, so this is what was requested by this trainee. You can see there's some demographic details about the trainee, and then the supervisor will give the degree to which they had to intervene, and therefore the degree to which they trust the trainee to perform various parts of the procedure unsupervised. I will not show more of this because this is more for the consultants and the registrars. It's also good to look at this to see what am I being assessed for, but this does come back to the registrars in the form of a report. So the supervisor completes the observation within 24 hours of the activity taking place, but ideally straight afterwards, and with the SMS and the email being sent, this should happen quite quickly. A report is then emailed to the trainee as well as to other consultants in the unit, and we very strongly encourage face-to-face feedback by the consultant to the trainee. And this vastly increases engagement, it vastly increases learning. This would be what happens then once the supervisor has completed that form. An email will be sent to the trainee as well as to the head of that unit and the other consultants, just so they know that where that trainee is at for their procedure and how they can best help the trainee to grow. So it says which procedure was done and when it took place, and please provide some feedback. And you can see attached is a PDF of the observation report, which will give the trainee and the consultants a detailed feedback of that observation. What also happens is each observation is stored in a Google Drive folder. These are, of course, confidential and very strictly secured. Each trainee will have their own folder, and their observation reports will go into that, along with their logbook and the end of block assessment. So all of the observations of competence and progression are stored in one place. They can be reviewed periodically. So the workplace-based assessments or observations are stored in this folder, and they can be reviewed. For example, here's an operative assessment, and the date is given. And there's the observation that comes through, gives all the metrics of how the trainee was assessed, for example, surgical plan or strategy, technical skills, and a description of what it is. And then the consultant for each of these, it's not a score from 1 to 5 or 0 to 100%, it's how much I had to do, which translates to the independence that the trainee has to perform the activity. At the end, obviously this is a test case, but there would be some feedback about what was done well and suggestions for how things can be improved. And a reminder of the different levels of trust, which is how they're going to rate the trainee here. All right, if you have any questions, please feel free to contact me, email or phone, and thank you very much.